Hello guys, welcome to the channel. Welcome to Health, Music and Fitness channel. And today we'll be discussing ECG again. This is the second lecture. We have started all the lectures again, all over again for the second batch. And yesterday, day before yesterday, we discussed the important things about ECG.
Hello guys, welcome to the channel.
How to take an ECG and what an ECG is and how to record an ECG. Today I am all alone because my partner Eric he has gone for a birthday party of his friend, so there is nobody to assist me. So there might be little delays or something, but anyway I think we can continue. So in the previous ECG we discussed about what an ECG is, what an ECG paper looks like. There are small squares, 5 small squares horizontally, vertically. One small square is 0.04 seconds in duration and 0.1 millimeter in 1.1 millivolt in height. Okay, and then we discussed about calibration, that it should be 10 small squares in height, horizontal, plateau and downwards. And we discussed about the different leads, and we discussed there are 6 anterior chest leads, V1, V2, V3, V4, V5, V6. And for recording the right ventricular infarction or right ventricular changes, we have to take V2R, V3R, V4R, like that. Okay, and for posterior wall MI we have to take leads V7, V8, V9, like that, posteriorly on the left side. So this is very important, and usually we don't take these leads, we just take lead 1, lead 2, lead 3, then AVR, AVL, AVF and V1 to V6. And sometimes the machine gives a long lead too. That lead we get so that we can comment on the various arrhythmias like complete heart block. So we need a little longer strip to discover and recognize AV blocks, type 2 blocks and type 3 blocks especially. Okay, so that is very important, and we will just skip these and we'll come to this circle again. I'll bypass this also. So just to recapitulate, you have to see the different leads in the placement. For first 100 ECG or something, you have to think of the circle again and again in your mind, and automatically you have to train your mind to record those complexes which you are seeing on this circle. Okay, so lead 1 is at 0 degree, lead AVF is at plus 90 degree, and minus pole of lead 1 is at 180 degree, minus pole of AVF is at minus 90 degree. This is minus and this part of the hemisphere is plus, positive. So this you have to know, it's very important. And also you have to remember electricity doesn't travel like this, it travels either like this or like this. And these lead 1, lead AVF, these are the positive poles of all these leads. Okay, and whenever the current is coming towards these leads, positive pole of these leads, it is perceived as a R wave and upright deflection. But when it is going away from that lead, it is perceived as a S wave or a negative deflection. So let us say the impulse is going like this from SA node to left ventricular side. So it is like going diagonally towards the LV tip. Okay, so lead 2 is at plus 60 degree. So this circle is very important. We cannot bypass this circle because otherwise the whole fun of interpreting the ECGs goes. So see, SA node is out here and it has fired, it has impulses stimulated the atria, and then it comes to AV node. There is a little delay, bundle of phase divides into left bundle branch, right bundle branch. Left bundle branch divides further into left anterior fascicle which lies superior laterally and left posterior fascicle inferior medially. Okay, so for lead 2 the impulse is always coming towards lead 2. Okay, so it is perceiving as a good P wave, good R wave, good T wave. At this time when this is happening, what is happening for AVR? You just remember this diagram, it works. It is my own imaginary diagram, but it works. Okay, so for AVR the impulse is always going away. AVR is out here and SA has fired, and the impulse is going like this towards LV. So for AVR it is always going away from AVR. So AVR is unhappy, it says ki I am not getting some positive electricity, positive impulses. So AVR draws a negative P wave, inverted P wave, inverted QRS complex, inverted T wave. Okay, then next thing we discussed is T follows R. If R is of good amplitude, T has to be of good amplitude. If T is not of good amplitude and R is tall, okay, in that case you have to think of some myocardial ischemia or something like that, or some electrolyte imbalance happening, which is causing some deviation of the T wave, making it flat or inverted. So, this all we have discussed. So, we discussed about the pacemaker. So, this is pacer. So, SA node I told you is the pacer. Okay, I have edited these pictures little bit. So, these guys, they are the pacers and this is the athlete. Okay, then this is my little one, he is running his first race. His people in guys in red t-shirts are his competitors, and I am pacing Eric, and you can see like the camera guy had spotted the tears. I was actually crying with happiness, that my son is running with me. So that was a very heart-touching, heartfelt moment, and we ran. So this is like sinus bradycardia. This is in the middle of the night. We are running a 42-kilometer race, and slow and steady we are running. So sinus bradycardia is like that. This is like sinus tachycardia. I'm just sprinting, I'm finishing the race, and this guy is like junctional bradycardia. So he's tired and he's slow. This is just a simulation. And so SA node controls the heart rate. If SA fails, the atrium might pick up, or the AV node might pick up the impulse, and it might start firing and stimulating the heart. Okay. And if AV also don't fire, then the ventricular pacemakers will take over and try to sustain life. And those type of ventricular beats, they should not be suppressed. It is very important. You should not suppress those beats, because that they are trying to sustain life. And if you give some beta stimulants, if you give adrenaline or atropine, and you will see if the heart rate, if with 1 or 2 shots of atropine or adrenaline, the heart rate comes to around 40 to 60, the AV node will try to pick up. You increase the isoprenaline drip or whatever medication you are giving to cause tachycardia, you increase it furthermore, the SA will try to pick up. And many a times in complete heart block, this thing works, and you increase the dose of the medication and the corresponding pacemaker gets some support. The SA will try to pick up and it starts firing, and the P waves will start coming in the this thing, ECG. Okay. So that is very important. This is another take home message. If you give the medication and you increase the stimulation to the corresponding heart rate of particular node, AV node or the SA node, then that pacemaker gets some support and it tries to pick up, and most of the times it will pick up. Okay. So this we have all discussed, and I'll just go. Okay. So P is because of atrial depolarization, QRS is because of ventricular depolarization, and T is because of ventricular repolarization. So you will ask, sir, where does atrial repolarization show on the ECG? Atrial repolarization is occurring when the ventricles are depolarizing. So ventricles, I told you, they are very bulky. The LV is the main guy that controls the configuration of the QRS complex. So it will not let the small atrial impulse to show. Okay, so that time, so P wave repolarization, atrial repolarization, you cannot see on a conventional ECG. So this is the same diagram. So in AVR, everything is inverted. If something is positive in AVR, something is wrong, and grossly wrong and badly wrong, and morbidity and mortality increases. If there is MI and there is some sort of ST elevation in AVR, it is considered as a bad prognostic sign. Okay. So can you guys hear me? So yeah, I'll just see the comments. Some of the comments are not showing in my phone. I don't know why. I'll just hold on, guys. Today I am alone, so apologies for the interruption. Yes, now I am seeing. Good evening, everybody. Now I can see all the comments. Sankavi, Dileshwar, Harini, Anushka, Amritya, Priya, and yes, okay. Thank you, guys. Thank you for joining. So, okay. So this is very important. Okay. So AVR will show all inverted P waves. P wave, inverted QRS, inverted T wave. If something is positive, let us say the P wave becomes upright in AVR. What does it mean? SA node is out here, AV node is out here. SA has stopped firing, AV node has taken over. So to stimulate the atrium, AV node will backfire like this towards the atrium. So the impulse is going towards AVR, then AVR becomes very happy, oh, P wave impulse is coming towards me. Then AVR starts showing an upright P wave. Okay, that is very important. In that situation, at that particular millisecond, when AVR is showing upright P wave, rest of the complexes which are towards these leads, lead 1, lead 2, lead AVF, they will show inverted P wave. Okay, because then in that case, for during the time P is getting stimulated like this, the impulse is going away from these leads. Okay, so they will show a negative P wave and there will be a positive P wave in AVR. So in junctional rhythm, you can get a spotting or a MCQ also, and with an upright AVR, upright P wave in AVR, and you can be asked what is the rhythm. So the answer is some junctional bradycardia, some junctional beat going upwards, and that is the diagnosis. Okay, so again we'll just focus some time. So see, I have plotted V1, V2, V3, V4, V5 and V6. So V1 and V2, they look over only this much part of the right ventricle. Rest of the right ventricle is outside the domain of V1 and V2. Okay, so this will be seen if we take V3R and V4R. Okay, in that you will see the right ventricular changes. And I also told you impulse travels from left to right, and the first part of the myocardium, ventricular myocardium, to be stimulated is the interventricular septum. Okay, so hi Javed, thanks for joining. And okay, so the impulse travels from left to right, okay, to an interventricular septum is the first part of the myocardium, ventricular myocardium, to get depolarized. Now see, for V1, impulse is coming towards V1 when the interventricular septum is getting depolarized. So keep in mind, so V1 will show a small positive R wave, because interventricular septum is not very bulky. It is a small muscular structure between the left and the right ventricle. It is a common wall, you can say. Okay, RV is out here, LV is out here, there is a interventricular septum in between. So like that you can imagine. So impulse is going towards V1, V2, V3, V4, mainly V1, V2 when it is stimulating the interventricular septum. Okay, and for that time, what is happening for these leads, lead 1, lead AVL, so they will record a negative wave. Now which is the first negative wave that will appear before the R wave? That is the Q wave. Okay, small normal Q wave. So it will be denoted by a small q, not a capital Q, but from the aesthetic point of view, everybody writes a capital QRS even if it is a small q. Okay, so when the V1 is plotting a R wave because of interventricular septum depolarization, V5, V6, AVL, lead 1, they will plot a small q wave during that time. Okay, I will come to that another ECG, and then I will show you this. So this we have discussed, this we have discussed. Now we will start the lecture for today. So this we have all discussed, I have told you. Okay. Okay, so this is the picture I wanted to show you. So now see, impulse is stimulating the interventricular septum from the left bundle branch. There can be septal fascicle, or the left bundle branch stimulates the interventricular septum, or left anterior fascicle, the septal fascicle comes, or the left posterior fascicle, the septal fascicle comes from that. But interventricular septum is getting from left, depolarized from left to right. So V1 records a R wave. During that time in V6 you will see a Q wave, small Q wave. Okay. Then comes the S wave in V1. Okay. Now we are dissecting the ECG. If you understand this part, you don't have to by heart anything in the ECG. Okay, it is just like maths, like I said before. If you know this, you can on the spot diagnose a disease in the ECG, problem in the ECG. Okay, now there is a S wave forming after the R wave in V1. Now something must be happening in V5, V6 in lead 1 AVL. During this time when the S wave is forming in V1, there is a R wave forming in V5, V6 lead 1 AVL. Why? Now this stimulus has stimulated the left ventricle, R has formed in V1, then the impulse goes like this. Now see, this arrow is bold because the left ventricle is bulky. Okay, and the left ventricular electrical impulses, they dominate. Okay. And so there is a R wave, okay, in V6. Okay. Now I told you the impulse, the effect of left ventricular electrical activity, it will also be seen in V1, V2. Okay. So in V1 you will see a S wave during this time when there is a R wave forming in the leads which are lying over the left ventricle free wall. So which are the leads at 0 degree? Lead 1, at minus 30 degree lead AVL, and in lead 2 out here, okay, V5, V6. V5 I told you it lies at the tip. Okay. So the take home message is a small Q wave in the lateral leads, mainly in lead 1 AVL, V6, V5. Okay. It is a normal presentation. Now supposing this Q wave becomes very deep, okay, it will indirectly mean that the interventricular septum is very hypertrophic. Maybe there is a isolated septal hypertrophy, maybe there is a isolated hypertrophic cardiomyopathy, okay, or maybe there is a left ventricular hypertrophy in which predominantly the interventricular septum has hypertrophied a lot. So more bulky interventricular septum, more electrical activity, tall, very tall R wave in V1, very deep Q wave in V6. Okay. Or if this Q wave vanishes, then you have to think of septal infarction because the electrical activity has gone. Okay. So that because this negative wave is forming because of the vector, not because there is an MI. So if there is an MI, this thing will be undone. So the electrical activity from here, it will go towards the isoelectric line. I hope this made sense, but this is very interesting and very important. Now where is the R wave on the ECG? So we have discussed this. R wave you will see in V1, V2. V1, V2 covers little bit of right ventricle. Then rest of the right ventricle is outside the coverage area of V1, V2, which is seen in V3R, V4R. Okay. On the right side we have to take these leads. Now this is a diagrammatic representation. Like if you place an electrode inside the LV cavity, it will record only Q waves. Okay. All the leads will record Q waves because the electrode is in the center and the myocardium is around it, and the electrical activity spreading occurs from inside to outside. So it is always going away from the electrode. So all electrodes will show Q waves. So this is something you should remember. Okay. Now we come to the transition zone. So transition zone is something in which the R wave becomes taller than the S wave in V1 to V6. So you see in V1 small r, little tall r, V2 little taller r, V3, and R wave has become taller than the S wave. Okay. So this is the transition zone. So then R is tall, there is hardly any S, R is tall, no S. Okay. So this is the normal transition zone between V3 and V4. And if the transition zone moves from V3 and V4 to V2 and between V2 and V3 or between V1 and V2, that is called counterclockwise rotation. You are looking at the patient's from the patient's foot end. Okay. So the heart, let us say for me, patient is lying like that, patient's feet are out here. So I am looking at his heart like this. So counterclockwise rotation. Okay, like that. Then there is a clockwise rotation also. Now we will see some of the causes of counterclockwise rotation. So if the right ventricle is hypertrophied, so right ventricle will contribute little bit of electrical activity to the ECG when the QRS is forming, but now the right ventricle is very hypertrophied, it will contribute more. So you will get a more taller R wave, okay, and that will ease the transition between V2 and V3. So then WPW syndrome, some variants will show counterclockwise rotation. Now posterior wall MI. So posterior wall MI will again show counterclockwise rotation. Okay. Left anterior hemiblock. So you can by heart this, or if you imagine there is a left anterior fascicle and it is blocked. Okay. Then the current is going like this, and then there will be a counterclockwise rotation. Or if there is a shift of the interventricular septum to the right side, so then like in hypertrophic cardiomyopathy, so in that case there will be a counterclockwise rotation. Then in certain dextrocardias, like there are 3-4 types of dextrocardias, in true dextrocardia there is a reversal of the chambers. So, the LV will be over the right ventricular side on the right side and vice versa, like in situs inverter. So, there you can see counterclockwise rotation. Then we come to the causes of clockwise rotation. In that you have to remember there is a interventricular conduction defect which is secondary to myocardial degeneration that can cause clockwise rotation. Okay. And RV heart disease. Now see, right ventricle is trying to show its dominance, but LV is very strong. Okay. Now RV is having some heart disease, maybe cardiomyopathy or MI, and RV MI has occurred, and whatever it was giving little bit of electrical push, that also has gone. So, LV has totally taken over. So, it will take a longer time for the electrical transition to occur. Okay. Then shift of the septum towards the left side or just opposite of the counterclockwise rotation. In dilated cardiomyopathy, then shift of the whole heart. Then in emphysema, there is some rotation of the heart. Okay. So, that can cause clockwise rotation. Then there is a vertical heart in very thin patients and very thin tall people, you will see a vertical heart. In that also you will see a clockwise rotation. So, in detail, like you have to think about heart rate, rhythm and axis. Now, today we will be discussing little bit of axis and then I will close it. And axis is the most important part. If you bypass the axis, you will have missed some of the major diagnosis in the ECG, findings in the ECG. Now, see, I will show you this circle. We will come to this circle. Normal axis should lie between 0 degree and plus 90 degree electrically. Okay. But from clinical point of view, we take up to minus 30 as normal and up to 120 as normal, plus 120. Okay. So, we'll go electrically 0 degree to 90 degrees normal quadrant, normal axis. Then 0 degree to minus 90 degree, this is LAD quadrant, left axis deviation quadrant. Then plus 90 to 180 degree is RAD quadrant. Then minus 90 to 180, it is extreme LAD or extreme RAD quadrant. You will see the axis shifted into this quadrant in very bad COPDs or very severe congenital heart diseases. Okay. And in lung diseases you will see right axis deviation. In left heart diseases usually you will see left axis deviation. We will come to the detail of this in short while. And normal axis should lie between 0 and plus 90. So, at MBBS level, if I ask you what is the axis, you should be able to tell me in which quadrant it is lying. For that you have to look in lead 1 and in lead AVF. Okay. Now, this is the positive pole of lead 1, this is the positive pole of AVF. So, if lead 1 the QRS is positive, let us say in lead 1 QRS there is only a R wave, and in lead AVF there is a R wave. So, you plot 1 out here, AVF out here. So, in this quadrant the axis is lying. Now, let us say lead 1 has become negative, which means the S wave in lead 1 is deeper than the R wave in lead 1. Okay. So, that way. So, you plot it out here, and AVF, let us say there is R wave, little small S wave. So, R is positive, AVF is positive. So, we plot it out here. So, it is lying in right axis deviation. LAD from 0 to minus 90. So, like that. Now, this is right axis deviation. So, just remember that same circle in background like that. Okay. So, lead 1 is at 0 degree, 2 is at plus 60 degree, 3 is at plus 120 degree. Now, you see lead 1 is negative. So, by default what we see is, if lead 1, you can write it down, lead 1 and AVL, they will oppose inferior wall leads 2, 3 AVF. Lead 1 and AVL will oppose lead 2, lead 3 AVF. V1 and V2 will show opposite changes than in V5, V6. If there is a tall R in V1, V2, there will be a deep S in V5, V6. If there is a tall R in V5, V6, there will be a deep S in V1, V2. Okay. And QT is inversely proportional to heart rate. So, if QT is prolonged, you will have a brady. Okay. So, like that. So now see, lead 1 is, why this rule works is because current can travel either like this or like this. So if the electrical axis has shifted so much that lead 1 is plotted in this picture at 180 degrees, it means the current is going away from lead 1, okay, because there is a S wave, very deep S wave in lead 1. Now which are the other leads which are closer to 180 degree? Lead 3. Now you see in lead 3 there is a very nice R wave. So lead 3 is very happy that lot of electrical activity it is getting. So it plots a very positive R wave, and so you plot that on that circle. So lead 1 is negative out here, lead AVF, let me see if I can draw screen, okay, pen. So lead 1 you will plot out here, and AVF you will plot out here. One sec, let me change the color. So how do we change the color? In color, okay, I will go for red, okay. So out here and out here. So this is the right axis deviation. Now if the opposite was there, lead 1 was positive and AVF was also positive, then you will draw in this quadrant, okay. I am making a mess of my PowerPoint, but in the end I will not save it. Now okay, I will come back. So this was right axis deviation. Then this is the simplest way to find the axis, okay. Then I call it James law, because I discovered that if in lead 1 there is, if lead 1 is positive and AVF is also positive, then you just look at the R wave. The tallest R is the axis. I call it James law. And it will always be positive, and you will always be right. If 1 is positive, AVF is positive, then tallest R is the axis. Let us say lead 1 is positive, 2 is positive, AVF is positive, then tallest R is the axis, and usually the axis in that case will be at around plus 60 degrees. Then there is a third method. You look for the most isoelectric complex, and isoelectric, what I mean by isoelectric is where R equals to S wave. You have to look in the first 6 leads, not in V1 to V6, lead 1, lead 2, lead 3, AVR, AVL, AVF, okay. So in these 6 leads you look at the most isoelectric looking complex. In some leads you will see R is 5 small squares, S is 4 small squares. So that is sort of isoelectric if all other leads are showing predominantly positive or negative complexes. So you take that one. Then perpendicular to that will be the axis. Now let us say lead 1 is isoelectric in some ECG, okay. I will show you the axis ECGs later on after a few slides. The mouse is not okay. So let us say lead 1 is isoelectric, lead 1 is isoelectric. So what is perpendicular to lead 1? Lead AVF plus 90 or minus 90. Then you look at AVF. AVF is showing a positive complex or a negative complex. If AVF is showing a negative complex, you plot AVF out here, then it is a left axis deviation. But if AVF is positive, like in second method, so then the axis is normal, okay, and axis is around plus 90 degree. Perpendicular to the isoelectric complex, the axis will be there plus 90 degree. Now let us say lead 2 is isoelectric, lead 2 is isoelectric. So what is perpendicular to lead 2? AVL minus 30 degrees. So that is the axis. Now let us say lead 3 is isoelectric. So what is perpendicular to lead 3? Plus 30 degree, okay. So like that. Now you find out the axis. I have already given the title. So you see the axis in this. Now see lead 1 is looking, there is a R and there is a S, but it is not very isoelectric. Lead 2 is only predominantly positive, there is no S wave. In lead 3 there is a Q wave. Now mind you, this is another take home message. For determining the axis, you will not consider the Q wave. Q is not equivalent to the S wave, okay. So you have to look at the R wave and the S wave, not the Q wave. So you can't say ki sir lead 3 is isoelectric. No, we are not looking at the Q wave. AVR, no, yes, AVL, okay. So AVL is isoelectric where R wave roughly equals to S wave. So this is R wave and this is S wave. This is the most isoelectric. So what is perpendicular to R wave? So remember that ECG. So what is most perpendicular to R wave? AVL, sorry. So like that you will draw. Okay, AVL is out here. So what is perpendicular to plus 60 degree? That is lead 2. Okay, so the axis is plus 60 degree. If AVL is isoelectric, then perpendicular to that is lead 2. Lead 2 is at plus 60 degree. So like that you have to determine the axis. Then there is a fourth method of finding the axis. Today will be a short lecture. I'll just finish the axis and we'll wind up, because you people must be having some commitments, because it's Happy New Year, and Happy New Year to all of you again. So fourth method is you look at the x axis and the y axis. You draw a rectangle. So like this you will draw a rectangle. Okay, and you will see, I will show you. We have to go back to the same. Okay, now in this ECG you draw, you see lead 1, it's positive or negative. Now say, let us say lead 1 is R is 2 out here, and 2 positive, and S is 5, 6, 7, 8, 8 negative. So 8 minus 2 is minus 6. Okay, so lead 1 is minus 6. So lead 1 is out here. This is the center. So let us say you draw equidistant markings 1, 2, 3, 4, 5, 6, like that. Then you look in AVF. AVF is positive only. Okay, so AVF you will, I'll just cancel the pointer, it's causing problems. Okay, so AVF is 5, 5, 10, 15, maybe 16. Okay, so I will draw 16 positive AVF. So positive side is this side. So I will draw out here. So out here. So let us say 16 comes till here. So you will draw a rectangle like this, and then you will draw the diagonal to it, and whatever is the diagonal will be the axis. Okay, that this one works very very nicely. So whatever is R minus S or S minus R in lead 1 and lead AVF, you draw the rectangle and draw the diagonal, that will be roughly the axis in the ECG. So this method is pretty accurate. I'll teach you the tan theta method also, which is the most accurate. I think most of the TMT machines and electronic machines which record the ECG, that formula is fed in them, the tan theta method. So these are my just observations which I have made. So tallest R is the axis if 1 and AVF are positive. V1, V2 they oppose V5, V6. AVF opposes AVF lead 1 and AVL lateral leads. Okay, so lead AVF is opposite to lateral leads. Q is inversely proportional to heart rate. If R is good, T should be good. So we have discussed this. Now see, now we will use the tan theta method. So now you try to find out the axis. Dr. Javed, can you find the axis please? Anybody in the audience? I will give you some time. You can look at the ECG and see, and we'll see if we can find. I'll give you 2 minutes. Okay, there are no replies. Anybody? Dileshwar, Priya, Indu, Sankavi. So today the students are less. Okay, so now we come to the tan theta method. Okay, for this I have to give credit to Dr. Saurav. He worked with us and he was in my team. He was the SR, and he was the AP, and you can see out here Dr. Lakshana is also here. See, both of them are having puris and my plate is empty, so I am not taking trans fat. Okay, so Dr. Saurav and Dr. Lakshana are having puris. So Dr. Saurav taught me this tan theta method. So every time I talk about it, I give credit to him. That is one thing very good, and you should all do. You should always give credit to the person from whom you have learnt. Okay, Dileshwar says sir, image is not clear. Anyway, Dileshwar, carry on. Like, we'll come to the next slide. And so tan theta method is, again you look in lead 1 and lead AVF. So lead AVF, you see R minus S or S minus R. Let us say lead 1 is 4 positive. So you will draw 1, 2, 3, 4 equidistant markings. Okay. Then, and let us say lead AVF is 2 positive. So you will draw 1 and 2. So you will draw a rectangle like this. Okay, like this you will draw a rectangle. Then you draw the diagonal. Okay, so diagonal you will draw, and you draw the diagonal, and then it is divided into 2 triangles. So the rectangle is divided into 2 triangles. Basically we have to find this angle. Okay, so this is the theta, and then you use the tan theta method. I will show you on the calculator. And so tan theta equals to height by base. So now we have divided this rectangle into 2 triangles. So we look at this triangle. So height of this triangle is actually, this is the height, this is the base. Okay, so this will be the height. Okay, so the height will be 2 millimeters or whatever demarcation you have done, and base will be 4. Okay, we calculated this is 4 and this is 2. So height is 2, base is 4. You further simplified 1 by 2. So tan theta equals to 1 by 2. Then we have to find the theta. This is the theta. So theta equals to tan inverse and bracket height by base. Okay, and you calculate this. I cannot open the calculator on the computer because the whole OBS will crash. So you can do this in your phone. And yes, very good, Amritalya. It is around plus 30, but this tan theta method you will come to 26.8 something. Okay, so this is the beauty of this tan theta method. So this is what we do on rounds, and I teach my interns and JRs on rounds, and it's a very nice exercise. On many patients will pick up the ECG and will sort of have a competition. Okay, tell us, is it 20 degrees, 27 degrees or 24 degrees, and it is fun. So by tan theta method it will come to around 27 degrees. So it is that accurate. Now, so there are 4 or 5 methods of finding out the axis. Now you see, then what happens in myocardial infarction? The myocardium dies, there is infarction, so the positivity of that area decreases. So basically if the positivity is decreasing, it is becoming more negative. So you, let us say lateral wall MI. In lateral wall MI, what will happen? The lateral wall will get necrosed, and lead 1 AVL, they will become less positive, in other words more negative. So you plot at 180 degree. Okay, and lead AVF will be opposite to it only. So lead AVF will be at plus 90 degree. So it will cause right axis deviation. So anterior wall MI, especially lateral wall MIs, they will cause right axis deviation. Inferior wall MIs, the inferior part of the myocardium is gone, so the lateral leads get more power, so axis shifts to left axis deviation, because the more powerful lateral leads will pull and AVF becomes negative. Okay, so in inferior wall MI you will get a LAD, in lateral wall MIs, anterior wall MIs you will get RAD. So sometimes you can find out the MI based on axis only. When I was in CMC, like when I was working in ICU, we used to get 4 patients of MI just wheeled in directly, and we had to handle all of them. So we used to just look at the ECG while the ECG was being taken with us, with the machine, and we would say, okay, this axis probably this is this MI, and it is quite fun. So in this you will see there is anterior septal MI, there is loss of progression of R waves, there is a Q wave in V1. We'll come to this MIs later on, but I am just showing you because the ECG is here. Lead V2 there is a Q wave, lead 3 V3 there is a Q wave, okay, and this is a VPC. VPC we will say when there is no P wave, no premature, no atrial activity is there. So this is a VPC. So there is a condition indeterminate axis. So in that you won't be able to comment on the axis, and indeterminate axis, lead 1 will be isoelectric, 2 isoelectric, 3 isoelectric, AVR, AVL, AVF isoelectric. So you are actually stuck, so like in this ECG. So then we call axis is indeterminate, you cannot find out the axis. So you see this is isoelectric, AVF is isoelectric. So you can't say I will look at lead 1 because it is isoelectric, so axis is around minus 90 or plus 90. Okay, for that you have to look at AVF. Now AVF is also isoelectric, okay, sort of isoelectric. So axis becomes indeterminate. But if you use the tan theta method, then AVF is little negative, little more negative. Okay, so in that case it will be AVF is then has to be plotted at minus 90 point up, okay, vertically up. So axis will be LAD, and that's the beauty of tan theta method. You can be very accurate. Now these are the bundle branch blocks. So we will discuss these blocks in the next class maybe, but you can just remember and note down. Right bundle branch block will cause right axis deviation, R for right bundle branch. Rabbits here, it will show R as R dash pattern. Okay, so this much for today's class. And left bundle branch will cause left axis deviation, and both RBB and LBB they will have broad QRS with ST depression, concavity upwards and T wave inversion. So we will come to the detailed criteria in the next class. Then LAHB, okay, you can just remember by observation we have seen 99.99% of the times if there is a LAD and the ECG looks normal, like there is no coving, there is no hyperacute T wave or something like that, it is LAHB, left anterior hemiblock. 99% of the times LAD is because of LAHB. Okay. Then left posterior fascicular block will cause right axis deviation, but then you have to rule out everything, every cause of right axis deviation, right ventricular hypertrophy, pulmonary embolism and bad COPD or hypertrophic cardiomyopathy. So all these things you have to rule out, you have to do an echo, and then probably you can say safely probably this is a left posterior fascicular block. So left posterior fascicular block is a diagnosis by exclusion. You cannot just entertain right axis deviation and say this is left posterior fascicular block. You have to rule out everything. Okay. So in right axis deviation there is a, in right bundle branch block there is a right axis deviation. So let's see if there is a right axis deviation in this. So lead, let's see the most isoelectric complex, R equals to S, yes, there is a R wave only in lead 2, there is a R wave only in lead 3, AVR no, lead AVL also looks little isoelectric, R is there, S is also there, but not as much as lead 1, AVF is positive. So most isoelectric is lead 1. So what is perpendicular to lead 1? AVF. Lead 1 is at 0 degrees, positive pole of lead 1, negative pole of lead 1 is at 180 degrees. So what is perpendicular to lead 1? Minus 90 and plus 90, and lead 1 is positive, lead AVF is positive. So we will plot the vertical part at plus 90 degree out here. Okay. So axis is right axis deviation. Now lead 1 is positive. Okay. So whenever there is a predominantly positive complex, axis is around there only. Now see, there is no S wave in lead 1. Okay. So axis has to be around lead 1 only. Maybe it is lead 1 or AVL or at plus 30 degrees, axis will be hovering around there only, because the current is coming towards lead 1. So it's coming towards lead 1, AVF has become weak, and AVF you can plot at 90 degree, minus 90 degree. Lead 1 is positive, AVF is minus 90, lead AVF is positive, lead 1 you plot at minus 180 degree. Okay, you can just by heart it, it will work, it never fails. So lead 1 is positive, so I will say axis is around, right now I am just looking at lead 1. Okay, so axis is at 0 degree. So I will look at lead 2, there is a R and a S wave, this is a VPC. Lead 3 is a Q wave, patient has had MI. Okay, and this is lead 2 and AVR is inverted, T has become upright. See, I told you, whenever there is something positive in AVR, something is serious in the ECG with the patient. AVR is upright out here. See, there is an upright T wave. So MI has occurred. Probably this is a recent MI only. There is slide coving still in the lead 3. You have to become this smart that you have to pick up this coving. Okay, most of the times people will miss this, but you have to pick up this coving. Okay, this is coving T inversion. Okay, so V1 Q wave, V2 Q wave, V3 Q wave, so V4 Q wave. So this patient has MI everywhere. There is a anteroseptal MI. We'll discuss if it is between V1 to V3, and this is extending to V4, V5 also. You see R wave is not very tall, so ischemia is there also. Okay, almost the whole of the anterior wall is involved, and so in that there will be a lead 1 is positive and AVF is negative. So there is a LAD. Now see, sometimes there will be some arrhythmias or some blocks which will complicate the situation. So it's not purely like anterior MI, RAD, inferior MI, LAD. Now this patient had inferior wall MI, there is a LAD, okay, but there is a anterior wall MI also, anteroseptal MI also. So sometimes it will not work, but most of the times it will work. Okay. And when do you call there is a Q wave? When you don't see any upstroke, upslur in the QRS complex. Sometimes if you see slightest notch like this and there is a negative wave, that is R and S. Okay, don't make it a Q wave, your diagnosis will totally change, you will be wrong. So now see, lead 1 is negative, R is small, S is deeper. So lead 1 we will plot at 180 degree. Okay, lead 2 is very positive, very happy. Lead 3 is also little too happy. Look at the T wave, it's inverting. Okay, so once good R, tall R, but T is inverted, something is wrong. Okay, so this is an observation. If R is good, T has to be upright and good in size. So there here T is extra tall, so it's 5, 10, 15, 20. Okay, so it's meeting the criteria of left ventricular hypertrophy. So there is very tall R wave in V5, V6. So electrical voltage criteria, I will teach you how to diagnose left ventricular hypertrophy. There are 7 or 8 voltage criteria. Will not cover right now, otherwise it will be confusing. But this is extraordinarily tall R waves. So the ventricle is very hypertrophied. Okay, and ventricle is so hypertrophied that it is causing too high R waves. Okay, and like in HOCM also you will see hypertrophic obstructive cardiomyopathy, you will see very tall R waves, so tall that they will cross the paper. If you have the traditional ECG paper, it will cross the width of the paper, and in that case the machine will sense that and it will configure the calibration to half of it. So it will not go 10 small squares, it will go 5 small squares only. So if there is 5 small squares out here in calibration and this R wave in V5 is, let us say, 20, then actually it is 40 because calibration is showing just 5. So this you have to remember. So this is we'll discuss this in the next class, and this will become complicated. So thank you all for being here, and I have to discard this. So thank you everybody, and thank you for watching, and read the book. And the best book which I recommend is Hampton made ECG Made Easy. So first you read this book, and then after that you can read Leo Shamroth, that green book. It had the newer edition has come, it is not very good, I didn't like it. The older one, green edition, is very good. Leo Shamroth, green edition. Then after that, if you want to go more further deep into these ECGs, you can read Marriott and Goldman. So then you will be a master in the ECGs. So thank you so much for being there in the stream and commenting. And probably tomorrow also will have the class at the same time, 7 p.m. and tell your friends also to come, and stay healthy, eat healthy, and be good, and God bless. Bye bye.